artificial intelligence poses a threat to patient safety. So I'm going to stop speaking, and I'm going to ask now Professor John Fox to take the podium. Thank you, John.
Thank you. Good morning, everybody. I don't about my own device, I think, terrified after that presentation. About presentations, but I do my bias every rule that he listed for us. But I should say, you will gather from that I'm not a surgeon. I've been interested in AI medicine most of my career. This little thing at the bottom is the timeline. It starts in Pittsburgh. I'll say a little bit more about that later. I worked in the LRC and ran an AI lab for about 25 years. The Sierra UK, spent some time at the Royal Free and UCL and Oxford. So I've been around a bit, but there's been a sustained commitment, really, to the idea that AI is hugely important in many ways. But I've always had a huge respect also for the skills of clinicians and the challenges to patient safety that we have to address. I'm not going to talk more than a tiny bit about robotics. I'm going to leave that to Pablo. It's not my area. I'm going to talk more generally about clinical practice and medical expertise. Now, do I know which? There we go. But I have to start with this man. One or two of you might know him. A man called Tim Donald, who was, to get a photograph, I can find him. He was, I think, a cardiovascular surgeon in Leeds. And Tim was probably, in this country, the first person to try to use what we now call AI. I think we would certainly call, as he said this morning, statistical methods, Bayesian techniques, in order to do differential diagnosis. And he was particularly well known for some work that showed that quite simple statistical models could significantly improve on differential diagnosis of acute level pain. He was photographed before, but I worked with a gastroenterologist in Sheffield called Chandra Badan, and a medical physicist who's on the right of this picture here, called David Barber. We built a system for differential diagnosis of GI pain and put it actually on a doctor's desk in Chandra's outpatient clinic. And you can see a screenshot. Whoops, sorry, wrong one. You can see a screenshot here. Surgeons, I think, checklists are now popular among surgeons. And here is a checklist for taking a history. On the right-hand side is a summary of what's recorded by the clinician into this rather old-fashioned, you probably can't see it. There's a very old computer terminal on the left, in front of her. And then on the left-hand side of the picture here, we have a running tally of the likelihood of the number of final conditions that this patient might have. And we were interested in understanding all aspects of how the computer, that kind of calculation, might influence and hopefully improve the accuracy of diagnosis, particularly by relatively experienced doctors. But also it became very clear very early on, and this would be a theme from that too, that already what people are talking about AI, big data, knowledge algorithms and so on, they're already black boxes. You just had a bunch of numbers in front of you. And there were kind of huge issues which were looming even in 1980 and thereabouts. So as a quick summary, I reach back into my memory, and I would say there are a number of reasons why a mathematical view of clinical decision-making seemed the obvious scientific way of looking at things in those days. The maths was simple. Collecting the data wasn't, as we've already heard this way. But the maths was simple. It's the probability theory that you need, and the statistical decision model that you use were well understood. You used in lots of different areas, and they had potentially lots of different applications. At the same time, there were, and I will say are, issues about using computers, using even sophisticated AIs for decision making. There's a huge problem of collecting the data, the patient clinical data that you can use to collect parameters for these systems. There are issues of portability across different countries, different regions, and hospitals. They really actually don't do a huge amount. They're simply primarily for kind of deciding, is it this or is it that? Should we do this or shall we do that? And that really takes you quickly to the question. I think all the clinicians in the room will probably share my, I hope it's not a prejudice, I think it's true, that the way we think about complex problems great deal of uncertainty, we use judgment, which is a great deal more than simply multiplying numbers together. And that judgment and that understanding, that depth of knowledge that we bring to bear is partly what's needed to do the job flexibly and well. It's partly what's needed for us to be able to discuss and argue and debate about complex and difficult cases. Now, some of those things have changed, and this has really been exciting over the last year, but I don't know whether to be enthusiastic about big data and machine learning and Google and IBM, Watson, and all the other things that we hear about literally every day. I don't know whether to be irritated or enthusiastic. But the claim is, the belief is, that we can now easily collect so much data that we can massively improve on those early problems. But we still have the others. The problem of doing the machines that are building the algorithms that are developing. Are they really going to be able to exercise and engage with clinical judgment and the judgment of a clinician about what is safe and what is the right thing to do for all sorts of complex reasons? Now, one of the reasons that I was very sensitive to this black box issue really early on was because I've been very lucky to work in Pittsburgh with these two men. The men on the left is Herbert Simon, on the right, Alan Newell. And they're two of the original founders of AI, literally, the first group. Herb was a Nobel laureate. He got to work on decision making and he for his Nobel Prize in economics. And Alan Newell, who I was a postdoc with, was really an engineer who was very interested in both AI, they were both clearly interested in AI, but very interested in the psychology of decision making, the psychology of judgment. And they wrote a very important book in 1972, I think it was published, called Human Problem Solving, which they set out, it's a very big book. They set out a lot of views and studies of complex people doing complex tasks like playing chess, long before IBM, Deep Blue, beat the world chess champion, doing logic puzzles, field improving, a variety of different, rather intellectual tasks. But they were interested in how people were doing it and what they could learn and help them to create machines that could do it as well as or better than people. They too had a view summarised here, which was actually surprisingly a lot of our expertise, whatever we're plumbers or surgeons. Our expertise is actually coded into lots of simple rules that we have, but just vast numbers of the bits of knowledge about what to do in what situations. But we apply that to an understanding of the world, the real world, the physical world, which is at the moment machines don't have. And they understood that. I was enthused by this. I was in Pittsburgh. I thought, oh, maybe we can use these sorts of techniques to do something useful in medicine. And somehow I blanked my way into this hospital, a Shadyside hospital. I started talking to the surgeons who said, oh yes, come on, we're really interested in what you want to do. I had this idea we can develop imaging systems for real-time use during the operating procedures. And so I was doing a bit of research to find out what this surgical stuff is about. And amazingly, I don't know whether these suites exist anymore. In Shadyside, they had a kind of a central corridor with 3 operating rooms on either side. And they let me wander about for a day. I don't think I was probably scrubbed up, but I wore a gown and I just kind of went and stood next to the surgeons doing a variety of different procedures. And I remember once sitting on one of them on the stool, leaning over as a mitral valve was being replaced in the patient. I don't think it would happen now. It turned out that kind of lay person to wander around in the same suite of operating rooms was quite extraordinary. But it told me one really important thing. It's too hard. It was too hard then. I mean, we've all been amazed by the imaging and the videos, the work that we've seen this morning. It's still, we also heard a lot of qualifications about the work that we've been doing in endoscopy. AI is going to give us a lot, but there's still a lot of issues surrounding its use. At that time, we couldn't even contemplate starting, let alone in robotics. So, over the next few years, I pulled in my sights and started working in a much more focused just on the decision making. And eventually ended up at the Royal Free Hospital, working primarily in academic oncology, which is regions who some of you may know, invited me along there, and I worked with the, particularly the breast cancer team, with a number of projects. This is the multidisciplinary meeting. There were two particular surgeons, Vivek Patkar and Mo Keshwar, who sadly died last year, who some of you may know. Vivek, who's in the pink, in the pink shirt, is reporting at the front of the MBM, and we projected various things, the usual sorts of things in the multidisciplinary meeting, but in particular there was a decision support system. And now Mr Irwin is going to be absolutely furious with me. These are unreadable slides, but you don't need to read detail. This is one screenshot of a system which is just a patient record, a summary of this particular history of the patient we discussed. And then, at any moment in time, the team can request that we put up a set of options, whether it's endocrine therapy or chemo or genetics, a variety of things that would be recommended by the AI for what might be offered to this particular lady. That's actually a short list with a long list that goes all the way down here, 200 items of things potentially that we offer in the NHS breast cancer service. But then each one of those, the decision making not only provides you with the set of options that are worth considering and discussing, but also the pros and cons. You see the green and the red blob, and then a little summary of what the rationale is for why that is being recommended, and that links back into the NICE guideline. In this particular case, it's a NICE guideline, but there are multiple guidelines. I think it was a consensus model based on 11 US, UK, and European guidelines. So we've got something which is much not solved black box problem, but we can something which is much more transparent and understand why this AI is making suggestions, something which a probability algorithm, big data algorithm generally cannot do. Another example is we did with the American Association of Clinical Endocrinologists. This was actually to advise and guide the management of patients presenting with thyroid nodules. I'll make that a bit bigger. You can see the graph, the picture at the top. It's a bit like a flow diagram, but it's really a care pathway, a model of a care pathway that the machine can understand and indeed can execute and help the care team through that process of care, with different decisions being made at different times and data being interpreted, and so on and so forth. I won't labour all of this. I just want to say we have moved on. I think we have models, which we don't hear enough about in all press surrounding AI, which are based on the kind of quite an simple, intuitive understanding of skills of decision making that all of us have, not just urgent specialist expertise with surgery, but we argue the pros and cons, and we have reasons, we can explain why we're doing things and so on and so forth, hopefully most of the time. So let me move on. Now goes dangerous waters, which I'm not really competent, and I'm sure I'll get taken to pieces by my opponent. But this is the obvious place to start, isn't it? How are we going to build robots in the future, or robotic systems, that potentially are also going to be acceptable and transparent and open, which I think, as professionals, I expect you all to demand and expect. And I expect your patients to demand and expect. When you're making recommendations for surgical intervention, you can explain in some detail why the computer is suggesting this rather than that. Well, let's go to Asimov for a moment. I'm sure most of you, actually, probably not all science fiction buffs, but some of you will know, there was these laws that Asimov proposed, which we discussed to death ever since the 30s or the 20s, when it was written. About we established some principles that robots of any kind cannot violate if they're going to be acceptable in human society. What it doesn't make it clear, of course, and that's why it's been discussed by philosophers and food scientists and mathematicians and all sorts of people, is how precisely we can build a computer, build a robot that you could guarantee would obey these laws. There's one that I'm rather old. I don't know whether he still believes this, and Russell Taylor, you may know. He had a kind of tongue-in-cheek kind of version of that for his the rules of intraoperative robots, what they were allowed to do and what they weren't. First and foremost, surgeons the boss, never run mock. stay where you're supposed to be, not got robots that need to kind of move instruments or whatever they're doing. And of course, don't push too hard. Humans have a certain expectation about what things physically things are going to happen. Again, it's a bit like Asimov. How do you make sure that a robot knows who the surgeon is? What it means to unlock when is something running lock, when is something doing something intelligent preemptively, because the robot knows that something's about to happen that might be dangerous. How does it know where it is? What does that mean? And what does it need to be too hard? That's entirely dependent on the person who's being pushed against. Now, actually, we can move things along. And this is a friend of mine, worked with a friend of mine when I was at ICRF, still was then, called Peter Hammond, who sadly doesn't do work at this time, but we were working on modelling chemotherapy protocols and care pathways. And he reviewed about 50 published protocols, protocols, and tried to identify what the safety rules within those protocols were, could he capture them in a generic way. And it's kind of more like, you might think it's more like common sense than mathematics. You anticipate hazards are going to arise. You know the consequences. So all surgeon does. You want an AI to know the consequences of an action or a suggestion. You want to schedule things for the best effect. There isn't an arbitrary order in which you can do things. You can look down that list. And the thing I thought was so important, and I think it should be picked up again, that Peter was able to do was to show that with a certain style of AI programming, you can capture those rules in ways that machines can begin to understand and apply in practical decision making. That's not here, it's not the place to go into detail, but I think that old work, it's neglected work, deserves to be looked at again. So, that's me, that's my position. Let me summarise it. I think there's a huge amount going on, too much going on, about AI at the moment, and there's revolutionary consequences in every field you think of, and particularly in medicine. I think there's a lot to be excited about. Whether it's truly revolutionary or not, I don't know. At the moment, it looks to me as though, whether it's in imaging or interpretation of other kinds of devices, there are very significant advances coming. What is not clear to me is, as we cast our minds forward to think about autonomous medical systems, in a way we now almost take for granted autonomous vehicles, whether we know how to safely deploy those. And if we bring in autonomous robots into a surgical setting, it seems to me at the moment we simply do not have the knowledge to know how to do that and ensure our patients have the best possible outcome and are safe. Thank you very much.
Thank you very much, John, for the opening speech. I'd like to now invite Pablo to take the stage, and we'll move reserved questions until you've heard both the debates. But keep thinking in your mind, guys, about using the voting system, and do feel free to go for or against even at this moment. Pablo, the floor's yours.
Thank you. my position on this is for the against the motion, and not only I believe that artificial intelligence will be safe in the operating room, but it's probably the only way that we can make it safe. And that's what I'll talk to you about. Right now, there's a big problem. We have about 260,000 deaths in the U.S. alone from medical errors. This is the third leading cause of death after heart disease and cancer. And it's not because we're not devoting money to it. We're devoting about 15% in the U.S. of the GDP. That's about $3 trillion just alone to medical care in general. And this is common in all industrialized nations. In the UK, we're spending about 10% of the GDP. And if you look at the progress over the last few years, the progress has been really modest. So this is a huge issue, and it's really worldwide. So if you look at all over the world, it's about 300 million surgeries performed, 16% complication rates, with about 9 million deaths, and millions of people that have long-term disabilities due to this issue. And why is this? Well, this is not because we have bad doctors. This is a lot of times because the coordination is poor between doctors, because there's a lot of variability in the way that we deliver care, and there's a lot of lack of accountability. There's also other structural issues such as insurances, people going through the safety nets, etc., that contribute to it. But when you look at across industry safety records, the airline industry, you have about 0.4 deaths per billion-hour operations passenger. In the car industry, about 100 to 200 times worse. And when you look at surgery, we can estimate, and these are my own, it's difficult to all put it in the same common denominators because it's really comparing apples and oranges. But you can estimate about 50,000 to 100,000 deaths per billion hours operation patient. Again, I don't want to oversimplify it. Doing surgery on a sick patient is very different than transporting somebody who's healthy. But nevertheless, it is useful to look at it in a common framework, just to realize there's a lot of room for improvement, and the orders, and that it's almost orders of magnitude worse than other industries. It's also a fair comparison because in all these cases, especially between the airline industry and surgery, you have a trained professional doing a risky operation that involves customers. And there's a lot of lessons. This was not always the case. So if you go back to the 70s, the airline industry had a terrible safety record. The car industry, again, had a lot of safety issues. And along the years, they've been implemented different techniques, and some of them we've actually adopted in surgery, such as checklists. That's one point. But if you look at the last few years, both the airline industry and the car industry, they sort of plateaued. They have plateaued because some of the techniques are actually hard to transfer from one area to another. So, for example, in the airline industry, they say plan your flight, operationalize your plan. They run through checklists, and some of those things are difficult to do in the car industry. It's just not practical. If I had gone through a checklist the first time I went on a date with my wife, I probably wouldn't be married by now. The same in surgery. There's a lot of lessons to be learned. What are some of the areas where AI can help? Well, in the car industry, for example, where you have orders of magnitude worse than the airline industry, some of those checklists, some of those operationalized, some of this training, they can actually, that's where autonomous cars are going. This is the reason why autonomous cars are really pushing to use artificial intelligence to get an order of magnitude better of safety. And the same will happen in surgery. So a lot of what you do and what you're trying to do in order to improve safety is encode skills, try to establish processes so that you can actually reproduce them in a standardized way. You're optimizing some of the procedures, and ultimately you're designing systems that allow you to disseminate that knowledge to all the all the people that are operating. So when it comes to encoding skills, it's useful to think about what is a skill. And this almost applies to almost any field. If you're talking about driving, we want to go someplace, you're planning your trip in your head, this is where sort of your main decision making is going. You're interacting with the vehicle, now it's starting to operate the car. And as soon as you start using your sensors, either visual or auditory, you're picking up signals for your environment. And an important thing that happens now then is you're using perception. And perception is really the interpretation of those sensors. So this is really where a lot of the intelligence, what we call intelligence, happens in both the perception and the modeling. Based on your interpretation of the environment, you modify the plan. And if you have good judgment, then you'll do the right thing. You'll avoid crashing, but you will make mistakes, and that's the point, that you learn from the mistakes. So you have to go through that loop over and over and over again, and after you spend many thousands of hours, then you acquire the skill of driving. And again, without oversimplifying, surgery, you can kind of break it down in the same blocks. And again, just a disclaimer, it's not the same, it's much more complex, but it's interesting to look at the similarities to see what some of the lessons learned from one area to another. And so in surgery, if you're resecting cancer, plan your operation. You may look for a dissection plane. You start interacting with the environment, cauterizing. This can be manual tools, or it can be a robot that is in this operation. You use your camera in order to look at an image. And then the key is that an expert surgeon will interpret what you're seeing, and somebody who has a lot of expertise will see a lot more things than are here in the image. To me, this just looks like a bloody mess. Who's an expert? There's a lot of cues in here. There's a lot of hidden structures. They're already thinking about what might happen when they interact with the tissue. So it's a lot richer. And this, going through this loop over and over, is really what really differentiates an expert from a novice. All the richness in the perception and the planning that you perform. Now, it's interesting also to plot any of those four blocks, perception, modeling, interaction, or sensing against each other. So if you plot perception against modeling, for example, you can see why in some industries it's been easier to encode those skills than in others. You go back to the 70s, and you look at factory automation, well, you have robots doing operations in a very structured environment, very well-known models, and it was easy to automate. Up in, for example, autopilots for airplanes, which are in operation today, it's also a well-known model. So we have mathematical equations that can describe what a plane is going to do when you apply certain controls to it. And that makes it much easier. When you start getting into more complex areas is when when your senses require a very high degree of perception. So if you're talking about autonomous cars, for example, now you can have anything crossing. It can be a dog, a person, a family. It could be a bicycle. It could be a road in very bad conditions. So the variability and the sophistication of the perception needs to be much greater. And therefore, and this is the area where artificial intelligence can help, because it can deal with models that, a perception of a modeling standpoint, are much more complex and uncertain. What I call intelligent surgery is not necessarily worrying so much about robots doing the operation, but about surgeons doing the operation, but viewing and perceiving the surgical site through the eyes of an expert. And this is where you require a high degree of perception. So, talk from Dr. Mori is precisely a good example of that. You're performing an operation manually, but all the information you're getting is being augmented by artificial intelligence in order to give you more information. And it's interesting to look some of the other areas like laundry. I wouldn't bet on laundry being automated anytime soon, because first of all, we don't have models for soft clothing, and second of all, it's also very difficult to interpret all the information that you need in order to interact with it. And autonomous surgery would require a high degree of perception and a high degree of modeling and planning. And this is not really our objective right now, but it is far in the future. Now, each of those blocks, remember, sensing, perception, modeling, and planning, in the last few years, we've had a lot of enabling technologies. On sensors, anything from all the sensors you have in your phone to LiDAR for autonomous driving. Perception and planning has been really propelled by artificial intelligence and specifically deep learning. So this is what's really enabled much more sophisticated models. And interaction, well, we've had robots coming online, and this is part of the technologies that we're working on. When you look at perception specifically, you can see how up to 2010, the ability for computers to perceive or interpret the world was limited. It was maybe stuck in error rates about 30%. And as soon as deep learning and some of the latest techniques that are being used right now got introduced, then the error rates basically started declining. And the interesting thing that happened over in 2015, 16 is that those techniques actually got beyond human performance. Now that starts being really interesting. And you can see how, well, ImageNet is really a bunch of outdoor images, everyday life. When you start applying that type of power to radiological images, then not only you may be able to perform better than humans, but you might be able to use information that is not used by humans. Now, there's always exceptions. This is actually a picture that I took yesterday as I was crossing Hyde Park. It's a fellow with pigeons on his head. I don't know, he was feeding them. Now, what would a computer interpret in this case? Is it a man with a hat? Is it pigeon? Is it new animal? Well, who knows? It will be interesting to test it out. But obviously, when it comes to images that are completely different, that the computer has never seen, it's possible that you make terrible mistakes. And that's one of the weaknesses of AI. To an American coming over to London, it's obvious what it is. It's a crossing that requires the raised pedestrian, and he just solved the problem by putting birds on his head. Being watched by a hawk up here. Now, humans also make mistakes. That's also the problem. A lot of the times the images are ambiguous and hard to interpret. Now, in terms of modeling and decision making, you're all familiar with the program Go a couple years ago, where DeepMind with this program was able to beat the best player at Go in the world. And that was a big feat. If you look at the history of board games and computing, back in the 70s, we started with the checkers, and had a lot of success. Checkers is relatively simple. It took another 30 years, 1997, for IBM to come up with Deep Blue and beat Kasparov. And then it took another 15, 20 years for Go, which was considered the next complex game, because if chess, you have 20 moves for every 20 possibilities for every move. In Go, you have about 200. It was always considered a game that you play with intuition. The fact that a computer could beat a human at a game in which intuition was considered to be a key component is pretty remarkable. The most remarkable thing is when it was initially done, the computer basically learned from experts. The year after, they used reinforcement learning. The computer basically learned on its own, and it just achieved a level of scoring that was completely impossible for a human to beat. So when it comes to using intuition, you always wonder when nurses know something is wrong, when the doctors, they can't put their finger out that they know something is wrong. How do you capture it? Well, this starts pointing to the fact that you might be able to actually do that with a computer. Now, an interesting, when you encode knowledge, you get a lot of benefits because you speak in a common language. You can share that language in real time. This is a project from Google which illustrates the point. You have a network of robots learning to manipulate through reinforcement learning, and they're all basically trying and doing trial and errors. You can be, all the successful strategies are kept, all the unsuccessful strategies are tossed away. The successful strategies are basically shared in real time with all the other robots performing the operation. So you can imagine now whether you have surgeons in operating rooms, if there's 1,000 surgeons performing operations and every one of their manipulations is captured, there's 1,000 surgeries for each, you have now millions of data points that are being shared in real time and used to optimize the operation. Now, how can we use this technology? So going back to some of the skills, this is why this technology is used in driving. So this is a video from Waymo, in which, when it comes to driving, if you want to perform at a different level of safety, well, you can plan your trip based on all the knowledge that's out there to give you the best route. When you start driving, the car is now aware of where it is, and it's not only where it is and where it's going, but all its surroundings. So it's modeling cars, it's modeling bicycles, it's modeling pedestrians. So you have the planning aspect, you have the sensing aspect, and beyond the sensing aspect, you also have predictions, because now you can start actually looking at what's going to happen. If you see, for example, the wheels of a car turning, you can anticipate that maybe that car is coming out. If you see a gesture from a pedestrian, you can anticipate that that pedestrian is going to cross the road. So that can really take the safety to the next level, and this is why it's so interesting in order to reduce the death rate for car accidents. Now, going back to surgery, how can we apply some of this technology? Well, if we could capture and measure all the information on all the cases that are being done out there and optimize it based on objective metrics, we might be able to really start causing an impact in a couple of areas. And I always divide, when looking for areas to improve, I kind of put it in two categories. Either you're improving quality or you're improving cost, and both are critical. So quality means that you're leveling the skills from surgeons to bring them to a minimal level. So you're trying to make everybody an expert. And by doing that, you're reducing errors and eventually improving outcomes. And cost is really critical. It's not because we're greedy, we want to make more money. It's because if you improve the workflow and the efficiency, you end up with a procedure that now is available to a much wider number of patients. One thing that happens in surgery is that usually they say, what happens in surgery sort of stays in surgery. We know what the diagnosis is for patients, we know the therapy, and we know the outcomes and the patient profiles, and you have databases and registries that capture all that. But we're really missing a lot of information that we know is important for the outcomes. And so if we can establish metrics that have enough level of granularity inside the procedure, now we get a whole different level of information. So you can start determining what the phases of the procedure are, what tools were used, how long they were used for, what was the stress of the personnel during the surgery, and using all this information and the decisions that were taken in order to really now optimize the best practices. And this is what these new technologies and the new phase of digital surgery will bring. It's the whole level of metrics that will allow to optimize the procedure in a much more objective way. Vision is critical, and when it comes to perception, this is what I was alluding to before. This is called a cystectomy procedure, view of the gallbladder. This is the view that you get. And in essence, this is what an expert would see. They would see the gallbladder, they would see the common duct, they would see the hepatic duct. And obviously the goal there is to get a critical view so you don't end up cutting the common duct. Now, what if the computer can basically give you this view so that now novices or people that are learning are seeing the world much more through the eyes of an expert. All of a sudden you get all that learning curve and all the errors that are done on patients, learning on patients, and you reduce it. That's the goal. If you can digitize every case, you can now all of a sudden have a database in which every second of the surgical procedure is described in some way. You know what tool you're using, what you're operating, what tissue you're operating on, what is the task that you're trying to accomplish, what is the quality with which we're performing the operation, and all that information is information that you can use to ask questions later on. But there's many low-hanging fruit in terms of extracting content that is relevant for the operation. You can start really predicting what it is that, what time is left, for example, in the procedure. Are you likely to have a complication or not? And there's a lot of information in there that can be used for a lot of the logistic management and the workflow efficiency of the procedure. So ultimately, the goal is really to take individual expert skills that we know are very good at expert surgeons and do a couple of things. One is, if you can encode them, you can now avoid the learning curve or cut the learning curve from people that are learning. And if they can take all that, you can create a database in which all the surgical procedures, simple and more complex, are described. Now you can bring people that are learning, and instead of having them see a few procedures and go operate on patients and learn on patients over the first 50 to a few hundred procedures, now you can have them practice on thousands of procedures before they even touch a patient. The same as a pilot walks into a cockpit, and they're not just seeing what can they learn from their mistakes. They walk in the cockpit with a minimum level of proficiency. The second thing that you do is even experts. When you do even an expert, they might have done somebody who's done a lot of procedures may have done thousands of one procedure. Consider them that those are like the top of the line surgeons. Well, but even in those cases, they're only limited to their experience. So how can we can pool that experience? Now all of a sudden we go from a few thousand cases to maybe hundreds of thousands of cases or millions of cases. And now you can really optimize the collective skills. And even those surgeons will always wonder whether their technique is really the optimum way of doing it. The problem is they don't have enough data in order to answer that question one way or another. Once you pull that knowledge, you can answer that question. So imagine you do that for surgery. And I imagine that you do that for other communities like anesthesia, perioperative care, postoperative care. All of a sudden now you have a completely different way of looking at the care of the patient and optimizing the care and the results. Now, the question is, well, this sounds great. It's a really nice idea, but is it ready? And what are the problems of actually implementing it? Dr. Mori, John pointed to some of the challenges that we may have in implementing this technology. Just wanted to go over some of the results and some of the papers that some of the studies that people have done that indicate that the technology is useful. This was a really interesting study, I think it was last year or maybe a little bit more, by Google at University of Chicago. They took all the electronic medical records from, I don't know, it was like 200,000 patients or something like that. And they run them, and this is notoriously hard because electronic medical records is unstructured data in which it's very difficult to really make heads or tails, and people have been wrestling with the problem of what to do with those medical records in a useful way. Well, they just ran them through this deep learning program, and they got results that predicted mortality, morbidity, and complications with pretty high accuracy rates. This is amazing because this is very complementary. This is something that humans will never look at. It's very complementary what humans do, and it's surprising that you can actually get good results from it. Diagnosis, obviously, the first place where artificial intelligence will really make an impact is in diagnosis, and we can start seeing some of the results. So in melanoma, for example, this was a study at Stanford. They took 130,000 images from melanoma, and they were able to prove that you get similar or better specificity and sensitivity than expert dermatologists. Again, how you use this, it's pretty remarkable possibilities because, like Dr. Mori was pointing out, this is a message that I want you to go back with. It's not so much improving the results of experts, which eventually we will when we pool knowledge, but at this point it's about leveling the playing field for those that are not experts. And it just happens to be that most of the care is delivered by non-experts. So you can imagine the possible impact that you may have in healthcare, just applying that principle. This is another example in which we are We take hundreds of procedures of in this case, sleep distraction, and we're detecting the faces. The interesting thing about this is you go through hundreds of videos, you annotate the faces, and then you have the machine basically predict it. The interesting thing is that there's some instances, there's two phases here. One is the sleep pouch creation, another one is the introduction of the bougie, which is a tube that goes through the stomach. The interesting thing is that at some point the computer is actually telling you that there's a movement of the bougie, even though the person didn't actually never annotate it. So that's an example where the computer doesn't care. It can get to enough level of granularity where a human cannot, and that's very complementary to what humans do. Now, other examples in other fields that are very relevant to medical is detection of anomalies. Detection of anomalies in robotics and computer vision has always been a very elusive goal, because you cannot possibly describe all the ways in which something is going wrong. There's infinite ways. Well, that's what deep learning is actually good at. So you don't know what's wrong, but you know there's a point here that is basically an outlier, and you can see how if you're performing a surgical procedure, computer may not know what is wrong, but it may know that something is just not going according to the plan, and alert the user before, or the surgeon before something happens. The same thing in autonomous driving. In autonomous driving, because there's so much money and so much technology being devoted, we're going to be basically stealing technology from them and applying it to medical care. In this case, it's anticipating what a pedestrian might be doing. In many cases, people are taking, just based on video, you can be anticipating 1 or 2 seconds of frames ahead of what the video is with a very high degree of accuracy. So you can imagine that if you're going along and cauterizing, before you actually go and put a hole into the aorta or into the mammary artery, then you can be stopped or alerted by the computer. So this is also very applicable to the problem that we have at hand. So in summary, when you look at, let me just simplify this a little bit. So when you look at what artificial intelligence is doing, artificial intelligence, the way I look at it is just a filter. So we are designed to consume information, not data. But data can be the way you can picture of the different stages at which we can start processing data. First is at the most basic level, visualizing it in a way that it can be consumed. And this is just describing what happened. That by itself would have a lot of value today, even if you just did that. But as you start applying algorithms, then you can start actually determining patterns and determining why things happen, interpreted by a human. Beyond that, you can start actually constructing models. And once you have a model, you can start actually predicting what might happen. So you can see, we're down here probably right now, but we'll be moving up the chain and starting to be able to predict what might happen based on a specific situation. And all this is just producing information. This information right now is essentially powering our perception, powering our modeling and planning. And this is the distinction between using artificial intelligence to empower humans or using artificial intelligence to make autonomous functions. Eventually we'll get to autonomy. There's an enormous value in just partnering with humans and making their skills better. And this is also a second important message that I want you to go away with. This benefit of artificial intelligence is that it's going to make us smarter, hopefully. There's always danger that by having technology, you become less skilled, but really the way to use it in a positive way is to augment the ability for us to see the world and to make decisions in a more objective way. So why will AI improve safety? Well, because it's going to allow us analyzing information with a very high degree of granularity. It's going to minimize surgeons learning on patients and medical staff. It's going to level the playing field in judgment and perception, allowing non-experts to see and decide like experts. And it's going to allow us to use skills objectively on an optimized pool of knowledge. Thank you very much.
Thank you very much, Pablo and John, for two great talks. If I can invite you up now to have a seat. We shall open up to questions from the floor for the next 5 to 10 minutes, and then we'll hear the closing remarks. So are there any burning questions? We've got mics around the room.
So,
James, please.
So we have some of the biggest technology.
There's always somebody in charge. And that's a little bit like I was saying yesterday when I was driving. It has to be clear, is it the car that is in charge, is it the human that is in charge? If it's ambiguous, then it leads to problems. In this case, I strongly believe, especially for all the decisions that are critical, always the surgeon is always in charge. And what the machine provides is just information that is feeding into the decisions. That has to be very clear. But obviously, if you have an assistant that is giving you bad advice, then there's always that line of like, well, I made that decision, but it was really presenting me the wrong information. That's the area where there might be more of a debate, and there needs to be a lot of work in order to tackle it. And when you try to design it, if you go to the FDA with a system that is even providing advice, if that advice can lead to hazard situations, you better have a really solid argument of why that is not going to lead to accidents and mishaps.
I did perhaps respond as well. I don't know the answer is reliable. And because in the British legal system and probably the American legal system as well, that will be settled by the courts, actually, once there's been some disasters. This is not a new problem. 30 years ago, 20 years ago, there was something called expert systems when AI, for the last wave of AI, suddenly became industrially exciting. And people were asking the same question. We were building all these systems to help doctors and all sorts of professionals, the oil industry, the engineering, and so on and so forth. People asked exactly the question, who's liable if they go wrong? And the FDA never decided. Essentially, everybody's waiting to find out because the courts will judge in particular situations and establish precedents. And I think that is the situation. I think what is happening is different now is the general public is having a debate about ethics and trying to establish it fair and put the parameters in which judgments will be made and who is responsible. I'll make some comments about engineering in a moment, but that seems to be this is now a socio-technical issue, not just a technical issue.
Just following on from that, I think liability is quite important in terms of adoption of AI as well, within surgical practice. And often adoption, certainly in UK practice, is very much based on evidence base. And so in terms of for future adoption of AI interoperatively, I know there's been some sort of adoption already, what do you think is the importance of having good evidence base prior to this being rolled out? Or what are your thoughts about that? Because sometimes in surgery we do things without any randomized controlled trials or any evidence base. So where do you think we should be pitching in terms of AI?
My response to that is twofold. First is to absolutely endorse this one by evidence. I mean, that's what medicine and medical science is about. We don't discover any more, just a lot of things because they're fashionable and neat. We have to convince our efficacy. I know at the time we did this, we published 15 trials of systems in mainstream journals that really try to show that we can improve decision making and benefit.
I think especially in this field where there's a lot of questions. I think you made a point where one of the problems is that a lot of systems are black box, right? So they made a decision, but you can't explain nicely exactly why. All the more important that you have an evidence-based, driven approach, and it will be really interesting to see what kind of tests, what do we design in order to determine whether a system is safe or not some level, it's going to be impossible to determine 100% that it's going to be safe for us. It's not going to be the right decision all the time.
Alex.
Thank you for your illuminating talks. We've had some brilliant examples this morning of how AI will no doubt impact clinical practice and most likely improve it, first by Dr. Moy, and also I think your data about dermatologists predicting skin cancer is very compelling. I have a conceptual problem with the black box that you just mentioned as a clinician, which is that I don't understand the black box of the algorithm, yet and I'm responsible for the patient, yet I'm being asked to trust the black box, which I don't understand, and also I don't know whether your algorithm with Verb is better than your competitor's algorithm. How do we quality assure this? How do we monitor this? How do we learn how to trust something that is so complicated that your most average surgeons can't, or even intelligent surgeons can't really understand, because computer scientists will understand it. How do you solve that?
No, that's a great question. I don't think it's a solved problem. My view is it's just going to require a lot of transparency in data sets, testing methods. A little bit the same as in computer vision right now. You can see part of the, a few years ago, actually back in maybe 10, 15 years ago, a lot of the data sets were not really shared. And it was impossible to tell when a paper published whether your algorithm, were you comparing the same thing or were you, what were you really doing? So the way the computer vision community solved it is that they had standardized data sets, they had a lot of transparency in the way that they apply the algorithms, and although the algorithm itself, you might not be able to explain it, everybody can test it, and everybody can test it on the same data sets. There's a lot of work being done also on algorithms that get to precisely explaining what it is that is happening behind the scenes by being able to ask questions to the system. Sort of why did you come up with this conclusion? And getting views. So that's a very active area of research. Because even in autonomous driving, it's a big problem to just come up with a conclusion, not really knowing exactly, very difficult to debug. So it's, all I can say is very active. It's a very active area of research right now.
If I could just add to that, to me it's not only the clinician who's trying to make a decision or give advice to one person based on 100,000 data points. And so and manage to translate that algorithm into something which is very personal. That's a huge human skill. But the other problem that we have at the moment, and I pray transition is temporary, is that everything's been dominated by marketing and business objectives at the moment. And I think clinicians, without wishing to be condescending in any way, I think are struggling to kind of understand what all these areas they need to do. Are there things that will augment and enhance their professional capabilities and offer help them be better doctors for their patients? Or is this just something which is a threat and will undermine their autonomy as well as the patient's autonomy? And I think this is the reason I've continued to argue, however good the engineering is and is going to be, we still have a duty of care to really address that issue of human information.
Okay, we have time for one or two more questions. Gentlemen in the back.
So thank you very much for the really interesting discussions. And of course, yes, the accepting of responsibility and liability for the decisions that the AI makes is an important question. And I believe it extends beyond, medicine as well, like in autonomous vehicles, drones, and so on. But my question is, ethics aside, from a technical standpoint, as experts, do you believe that we will ever reach a position where AI becomes, the superior decision maker? Do you think that will be an eventuality?
I'm afraid so, yes. In some particular circumstances, we don't know which ones yet.
I would agree to that everything points in that direction, just because the sheer amount of data that a computer is able to handle versus human can be exposed, even if it's just on that. There's been so many results, even with relatively primitive applications, that you have to think that over the next few years, this is sort of exponential, and it's only gated by the availability of data. And this is actually one big topic that is important to realize here. The results are only going to be as good as the data. And one of the limitations in the medical community is that availability of data. So in autonomous driving, it's easy to get images and things like that. In medical, you have basically orders of magnitude less data. And a lot of times, whether it's companies or hospitals or clinicians, there's just not a lot of, we're not really structured to share data, make data available for research, etc. But the more data there is, the more transparent it is, the safer and the more accurate the results will be.
Thank you. We have time for one final question, I'm afraid. I know people are very interested to carry on and suggest that you approach the speakers in the lunch break afterwards. One final question.
Sorry, thank you very much. In terms of adoption curves, you talked about in Dr. Moore's talk that your non-experts would find the most benefit to it. Then if you look at it, so say they adopt it first and then you have your key innovators, you'll have your experts not adopting the technology. In terms of responsible marketing, will there be a point where you can say AI is, well, non-AI surgery is less safe?
Non-AI surgery is less safe?
Yeah, because your experts won't adopt it, you'll have non-experts adopting it and early innovators. Along your adoption curve, will that be something to consider?
Yes, if there is enough evidence for it, absolutely. I think, again, all these technologies are a little bit of a double-edged sword. So, you can make non-experts act more like experts, but you would hope that that doesn't provide an incentive for those non-experts to come up the proficiency curve. And the way I like to look at these systems is it really is an opportunity for non-experts to not only operate safely, but also learn faster. I'm not sure I would coach it that way in terms of this is safer than a clinician in general, but this is a tool that a clinician can utilize to have a safeguard and to make sure that they go up the learning curve faster.
Thank you very much to our speakers. Actually, I've been noticing that during the question time, we've been getting some movement of the votes, and currently it stands that for the motion is at 29% and against is 71%. But we'd like to now offer closing remarks for our two speakers. So, John, I'd like to invite you first for your closing remarks, and then we'll take a final vote.
2 more slides. Of course, a debate sets these things up in an adversarial way, and you may have noticed that actually my opponents and I agree on a lot of things. And one of the core things we agree on is that AI has an important contribution to make, and that may partly explain your optimism that AI is going to change your world as well as the world. We can just no. Thank you. Go back to the beginning. Keep going back. Just that slide there. That's it. Okay. So I just want to go back here and. Right. Thank you. So I want to say we started with robots. I think what we're all open to is the idea that those robots are going to do really well in the future. I'd just like to say that Sir Dr. Gassenau wrote a book on AI, not on robots, but on AI, taking medicine in particular. Sorry about the cover. And what we try to do, we discussed this duty of care. What do people are AI designers, what is our duty working with professional clinicians to deliver a technology that is safe? And I think we kind of drew on what was the state of the art in software engineering, in AI, in psychology, in a variety of different areas to really sort of understand that. Some years later, many of you will know this book, Vactor's book on uncertain patient safety, and this just sets out a huge landscape, which we were hardly even aware of. And I think it just means there's an enormous amount of work to be done really to achieve what we thought technology was going to achieve. I think what's really important now is that we have the discussion around AI in an informed way, and a lot of people are trying to articulate some sort of ethics that are comparable to the traditional ones that you're familiar with. And don't take these seriously, but here's my starter for 10. Transparency of systems, my opponent and I have agreed about. Accountability, why did you do that? What was the work? Why were these systems working? Those didn't. I would add to that, I think we can solve the first two. That machines need to understand the world as a physical world in order to making plans, making decisions, and so on. Understand the world in much the same way as that people do. And maths and algorithms are abstract, and they will, I think, will inevitably lead to their own kinds of errors, which are going to be calling AI errors, not human errors. Clinicians need, I believe, to be kept in control and be able to intervene when that's appropriate. And also the machines must then respond in a way that is appropriate. Algorithms generally don't, as you from personal experience. So to conclude, there's a funny way around this. If you think that developing AI, as I'll caricature my opponent, saying he believes that some nice mathematics and some really good engineering will basically solve the problem, then you will vote against the motion. We're eventually going to solve the safety problem. I'd like to put to you that it's much more to it than that. That delivering something that is safe will create machines that are much closer in their world to our world and address the ethical issues that we as we move to the other side. And if you believe that, then please vote for the motion. So he is going to be a problem.
Thank you very much, John. Pablo, closing remarks?
Yeah, thank you. I don't really have much more to add other than to say that I think there's a lot of excitement around this technology. Again, the possibility of using this technology to really learn about procedures and safety is enormous. A lot of times, what I find interesting is when you start looking at artificial intelligence in almost any process, it's not only about the artificial intelligence, but you learn about the decision-making process itself. You learn about how people make mistakes. You learn about how people decide, and this is really one area that is very complementary to the way that humans operate today. When we're working on developing robotic systems, but we say that we're not a robotics company. We're really a company that is a surgical company, and in the next few years is really going to be much more about the information than the robot. The robot is really just a way of getting granular enough information on the procedure so that you can start measuring at a level enough of granularity that allows you to make some decisions. So this has happened in almost any industry. When cars, for example, when robotics started using in cars, it became initially about interacting, but eventually it became a way of getting enough information so that you could actually guarantee the quality. And right now we have a huge problem of quality in healthcare. The stakes are very high, and this is going to be our generation's responsibility to bring quality to the next level. And just in order to make that a reality, using machines to measure at the right level of granularity and being able to automate the analysis in a way that you generate information that is actionable for the clinicians is going to be critical. So I'm looking forward for those mishap rates to be declining over the next few years as we start making this technology more sophisticated and more practical in the operation. Thank you.
Thank you very much. So now, if I could ask you all to make your final vote And the motion is, remember, this House believes that intraoperative artificial intelligence poses a threat to patient safety. So let's see how we've done. We'll give you another 30 seconds. And while we're doing that, I'd just like to thank our two speakers, John and Pablo, for a very entertaining last hour of debate. And I'm sure you've got lots of questions for them in the lunch break, so please approach them. There's obviously I think let's stop there. Let's stop there. Okay. I think we'll call the vote to a close just about 5 seconds ago. It's a dead heat, so thank you very much to our speakers.
Thank you very much indeed. I guess a moral victory for John because he started only 20%. So, it's a real treat to listen to genuine experts in their field talk so definitively about an important and emerging area of technology that's going to transform the working lives of all the trainees operating in this room. You are the guys that are going to have to deliver this technology, so I hope you were listening. Right, onwards and upwards. We're now moving on to the plenary sessions. The plenary sessions, don't forget, the people that are presenting are playing for prizes. There is cold hard cash to be won. So we like a good, clean fight, which means that for the speakers we will hold you to time. We have a timekeeper who is Tony, who will signal to you when you're about to run out. Tony, can you remind me how long we've agreed? So we will have 8 minutes to talk and 1 minute for questions. We will have a 1 minute warning. I will stop you if you run over. Okay, we will not let you run over because we're running a little bit behind schedule. So we will call you down one at a time. We have judges, so very much Alison is Professor Davidson here. If not, don't worry, I shall judge in this place. So we will start. We will start off, please, with James Ashcroft. Is James here? Please come down, James. Okay. Right. So James is going to talk to us about the potential impact of neurofeedback and neurostimulation on the future surgeon. Many thanks, James. Welcome. Yeah.
Okay. Hi everybody, my name is James. Today I'll be talking about our work in some areas where we're trying to make the future surgeon. To begin with, I would like to show you this, and this probably doesn't look too unfamiliar to you. It's surgeons making the headlines, and that's for mistakes, which potentially could be avoidable. Now, a lot of research has been done into error, and a lot of developments have been made in education and training of surgeons, but we're still finding ourselves in the Daily Mail. So the aim of our work is to make sure no surgeons are making these errors. And we've done some research already into the surgeon using our methods of neuroimaging. And this uses near-infrared spectroscopy, so infrared light, which we attach to the head, which goes down to the brain. We then detect how much oxygen is in a specific area of the brain. And then that allows us to measure the activity of that area of the brain. So in this study, we looked at surgeons. We applied our neuro-infrared imaging to the prefrontal cortex, which is the attentional cortex of the brain. And we found that senior surgeons had much more activity in the prefrontal cortex compared to novices. And this meant that they performed better. So what this means is that if we can find a way of making sure that our prefrontal cortex is active, we could potentially avoid errors that are being made every day. So that brought us to transcranial direct current stimulation. And this is a method of neurostimulation which uses a very low current, which is applied to the scalp with 2 electrodes. The electrode then applies a very low current to raise the threshold of neuronal firing and means that neurons in the attentional cortex are much more likely to fire, and therefore are much more likely to attend to the task. It also has a secondary effect of developing synaptic plasticity, which may have benefits in training and reducing those learning curves, making our trainees pick up new skills faster. TDCS has been in the news quite often recently in academia for improving scores in academics, in the military for improving the function of our military service, and in the Olympics to improve the athletic ability of our sportsmen. In research, in decision making, we have studies which have found that TDCS gives much better scores in decision making tasks and risk taking tasks. In attention, we find that TDCS gives much better attention compared to sham and attentional network tasks. In stress, we find that TDCS actually negates the effect of stress and brings us back to our baseline levels. And in memory, we find this paper, which is a very big one from 2005, so many years ago, which already showed that TDCS is improving working memory in our patients. In the more athletic and music realms, we find in cycling, TDCS gives a much longer time to exhaustion in our cyclists and they can perform better. In musicians in New York, we find that TDCS gives much less variability in musicians picking up new songs. In skiers, we find that TDCS gives much more propulsive force in training when they are training on the ski jumps. And in strength training, we find that TDCS gives much better gains in squats and other strength-based tasks. And so we all want to look like that guy by the end of it. So our aim of TDCS is to take the surgeon who's liable to make mistakes. We then apply some stimulation to them, and we make sure that they perform at the very best they can. This is then translated to the operating room, where they make less mistakes, they perform much better, and that has a much beneficial effect on our patient outcomes. It makes a real difference to real people. Now the big question is, how safe is TDCS? And this huge review was released in 2016, which looked at 33,000 sessions of TDCS, and it found 0 serious adverse events, so absolutely 0 adverse. In terms of discomfort, about 15% of participants had a mild discomfort, which was usually a very mild headache, which immediately dissipated after the stimulation session. And about 39% of patients had a mild itching or a mild tingling sensation, which again disappeared at the end of stimulation. So it's very, very safe, and it's been tested in a great number of patients and in healthy volunteers as well. So I thought I'd ask you to get your phones out again if you could, and we'll get back onto Menti. So I want to hear what you all think about TDCS and the surgeon. So if you put these numbers in, we'll go to our first question, which is, would you be willing to have yourself stimulated by TDCS? So we've got 12 people so far. And this is the big question is, would you want to have TDCS to improve your surgical ability and to make sure that you're operating at the best you possibly can? And so far it looks like the majority of you who've answered would agree with that, which is great to hear. The next question even if you were assured that TDCS was safe, would you worry that it might affect you in some ways which we couldn't possibly predict? Some technical issues there. I don't think that's going to work. So maybe we'll just stick to this question here. So if anybody would like to comment, if anyone's particularly thinks strongly or against agreeing with TDSS or disagreeing, we'd love to hear it. Mr. Kinross, what do you think?
We'll take questions at the end, if you could.
Okay, fantastic. Fine. Okay, well that'll wrap it up then. I'm quite happy with that. One question we have. So most of you would agree, and that's it. So thank you for your time, and we'll take questions now.
Okay, thanks very much indeed. Any questions from the floor? So, I mean, I have a question. So I'm not quite sure exactly what experiment you've actually performed to test your working hypothesis that it improves performance. What work have you actually done to show that?
So we're undertaking our study right now,
Right.
and this is using a simple open surgical task where we use open knot time. We're imaging our participants with the Neuro-infrared imaging to get a baseline for them to see where they're at the moment. And then we're applying about 15 minutes of transcranial direct stimulation to try and whilst we're applying that, we also get them to repeat the task in the hope that they will have much better outcomes. And following that, we'll then image them again to investigate whether the stimulation has actually had a beneficial effect to the prefrontal cortex.
Okay, but you don't actually have any data currently?
Not from our students personally, it's very novel machine learning right now.
Okay, all right. So I'm not sure we'll take any further questions because we are running a little behind schedule, so we'll carry on. So thank you very much indeed, James. It's nice to meet you. Thank you very much indeed. We'll now have Urvi Karaman-Chandani. I hope I pronounced that correctly. He will talk to us about differences between infected and non-infected synovial fluids in observational study using metabolic phenotyping. Thank you so much. Thank you.
Infected, non-infected.
Genomics is the study of the chemical processes involving these metabolites. Unlike genes, mRNA, and proteins, which are not influenced by external factors, metabolites are influenced by things such as weight, medications, nutrient intake, things like smoking. And this allows it to be a useful diagnostic tool. Periprosthetic joint infection is the most devastating complication of a joint arthroplasty. The gold standard for investigating the bacteria in this infection currently is via microbiological techniques such as MCNS. However, this can be complicated by polymicrobial infections and bacteria and biofilm-producing bacteria. Other infection markers currently under investigation include things like alpha-defensin and leukocytesterase. However, these don't identify the causative organism and currently need more independent validation. Metabolic profiling is therefore a novel technique which examines low molecular weight metabolites, and it can analyze small molecules within a synovial fluid sample. It can identify thousands of small molecules within a synovial fluid sample simultaneously and identify the presence of individual biomarkers that can then ultimately be used to identify unique metabolic fingerprints of a particular microbe. The hypothesis of our study was that there would be a different metabolic composition within the infected and non-infected synovial fluid. So synovial fluid was harvested from 8 patients with proven infections and 8 patients with non-infected joints. The infected synovial fluid was taken at the time of, was taken during aspiration, arthroplasty, or surgery for revision surgery for infection. The non-infected synovial fluid was taken at the time of primary arthroplasty prior to incision of the capsule. There was no significant difference in the patient age or gender, and the type of joint the synovial fluid was taken from was matched as closely as possible. Patients were also matched for medical comorbidities, in particular diabetes, but also ischemic heart disease, hypertension, hypercholesterolemia, and cerebrovascular accidents. So these samples were initially centrifuged, the supernatant removed and frozen, and then during analysis it was defrosted, a sample buffer was added, and then NMR was performed. Then, with the assistance of a multivariate analysis, the significant metabolites were identified. This is an example of a typical NMR spectrum that you got from one synovial fluid sample. Each peak represents a different bond in a particular metabolite, and the integral of the peak represents the relative concentrations. To analyze the NMR dataset, which had over 27,000 variables per sample, we initially made use of a principal component analysis. Now what that was is it allowed us to have an unsupervised method of giving an overview of the data variance in a simple 2D plot. So the score plot shown here, each point represents the entire spectrum of one synovial fluid sample. The principal component 1 on the x-axis explains 38% of the data variance and shows a clear divide between the infected and non-infected samples. That's something that we expected, and it suggests that there is, in fact, a difference in the metabolic compositions between the two groups. We then conducted a univariate analysis on the different metabolite concentrations within the two groups. The image here shows a stacked spectra of all 16 patients demonstrating metabolites that were found to be in significantly different quantities. The red shows the metabolites that were found to be significantly higher in concentration in the infected group versus the non-infected group. So these were the fatty acyl residues, cholesterol, and N-acetylated 2 groups. If we zoom into those three in greater detail on the side here, you can see that the significance is quite easily seen. Following on from this slide, this table just shows the significant difference in the metabolites with their associated p-values. This table provides an explanation for why the metabolites were raised in the infected cohort. It also shows that the results correlate with findings of other studies. For example, Heiko et al. Have postulated that cholesterol may be involved in the ApoA pathway, which is responsible for mediating the inflammatory response in infections. It was also important to note that NAC1 was reduced in the infected cohort, and NAC2 was increased in the infected cohort. And the fact that one is increased and one is decreased implies that they're both involved in the same reaction pathway, one as a substrate and one as a product. And although this remains speculation, the production of mucin in the infected synovial fluid might be the cause of the increased NAC2. Overall, the identified metabolites seem to be involved in defense against pathogenic organisms, lipid metabolism, and mediating the inflammatory response. So to conclude, there were differences in the metabolic profile of the infected and non-infected joints. The three metabolites were identified to be significantly raised in the infected cohort, and those three metabolites could be used as infection-specific biomarkers. The aim is that this would allow rapid identification of the bacteria present in the synovial fluid compared with MCNS. However, it's quite a small sample at the moment, and more data and further studies will be needed before we can draw such a conclusion. Thank you.
Thank you very much indeed. Well done. Sorry we're in the dark. Any questions from the floor? So, did you actually culture the organisms that were causing the infection?
So that's the next step. So initially we just identified that this particular fluid is infected using these three metabolites that we found to be significantly raised. We knew that they were infected because we sort of split our sample into two aliquots. We sent one for MCNS and we sent one for its NMR. So yes, we did culture them, and we're going to look into particular microbes and their particular metabolic profile.
So my question is, how do you know that the N-acetyl groups and the groups you've identified are causally associated with specific strains of bacteria?
We've looked at generally if it's infected or if it's not infected. I compared them with each other, and with the PCA we've shown that there is actually that difference.
Okay. Any other questions at all from the floor? Okay, we will keep moving just to make up a little bit of time. time. Thank you very much indeed for your presentation. Thank you. Okay, so we'll move on. Dimitris Karponis, hello, sir, who's going to talk to us, please, about the development and evaluation of a pneumatic surgical robot with dynamic force feedback. Thank you so much. Thank you.
Good afternoon, everyone. My name is Dimitris Karponis. I'm a fifth-year medical student, and today I'll talk to you about our pneumatic surgical robot with force feedback. As you can see, I started in my oblivion by violating one of the rules of good PowerPoint practice, as I have listed something you already know. So, moving on, as you already know, robotic surgery offers a plethora of advantages, particularly to the operator. However, it comes with limitations, namely the increased operating times, the high cost, and of course, the lack of haptic feedback, which is a primary mechanical challenge. So, haptics has two arms: kinesthesia, which is force feedback, and the tactile feedback, which essentially is the tactile sense, which allows us to tell how hot something is, or cold, or the shape of the object overall. And research shows that force feedback on its own reduces tissue injury, however, it increases operating time. Now, however, the problem here is that the inertial mass of the robot can actually mask the feedback. Fortunately, there are algorithms in place known as force scaling, and these allow us to change the force that the robot feels in order to adapt it to the operator who is operating at a distance. So a scale factor of 0 means no feedback, a scale factor of 1 means feeling roughly what the robot feels, and a scale factor of 2, for example, would be doubling the sensation of the robot to the actual operator. So with that in mind, we thought that increasing scaling factor actually reduces the force, when at the same time it increases operating time due to previous literature, and it increases user satisfaction up to a point, after which very high scaling factors overwhelm the operator and as a result may have impact in force. So to test this, we selected 4 different scaling factors from 0 all the way up to 2, and 2 tasks: block transfer as a simple task, and needle insertion as a more complicated task. Our primary outcome, as you may have already guessed, was measurement of force, but we also looked into operating time, depth of needle insertion, and user satisfaction. And in the back of my mind, we had to improve surgical outcomes and, of course, advance the prospects of surgical automation. So here you can actually see on your left-hand side our robot. It's called IBIS 6, and it has 2 arms, allowing 7 degrees of freedom. So just to put it into perspective, traditional laparoscopy allows 5 degrees of freedom. So if you pretend my hand is a laparoscope, you could have pitch, yaw, roll, zoom in and out, and grip. Now, our robot does exactly that, plus pitch and yaw at the grasper tip. It's controlled remotely by a haptic device. This is a Phantom desktop haptic device, and compared to the Da Vinci, it is more compact, it is lighter, as it is pneumatic, it's more affordable, it doesn't have any force sensors, as I'll just describe now, and arguably it is safe, as there are no electrical components in direct contact with the patient. So if we zoom in into one of the arms, here is the arm of the robot. It has 4 pneumatic microcylinders, 2 work in pairs, and if we zoom into one of them in blue, we can see how it works. So a pressurized air tank supplies compressed air into a servo valve. The servo valve is controlled by 3 factors: the potentiometer regulating the system, pressure sensors, and of course the operator. So making a movement, the master device will sense this movement and move the servo valve in the appropriate direction, allowing air into the cylinder, which will push the piston, creating actuation, and the resistance will be fed back to the operator as force. Now, how do we calculate the magnitude of this force? Well, it's simple. We have the pressure sensors, so all we need to do is actually follow the formula. So for our first task, for block transfer, we use 2 participants in a double-blind manner and ask them to perform the task 5 times, each on a different day, to avoid confounding. And here I have a video, hopefully it works. You can actually see the starting position of the blocks and the end position of the blocks, And essentially what's different from conventional block transfer is that our 3D printed pegboard has wider pegs, so it's more difficult to complete. And the molded blocks are actually narrower, as a result making it very challenging to put the blocks in the pegs quickly. For a more complex task, that is needle insertion, participants had to insert a 27-gauge needle all the way through a soft silicon sheet without damaging the hard silicon sheet just below that. And of course, after this, we measured the depth of insertion. So for our results, I'll show the combined results for both participants, and the error bars represent quadrature uncertainty. So for force, as you can see, for block transfer, increasing the scaling factor reduces force, but the only significant difference is between baseline and 2.0. For needle insertion, every scaling factor has a significant reduction of force. However, the biggest difference is between baseline and 0.5. In terms of operating time in block transfer, here we saw the opposite of what we expected. Intermediate scaling factors, in particular scaling factor 0.5, reduces the operating time, and we will see why that may be in the end. Next, the depth of needle insertion. Here it's actually quite interesting, because increasing scaling factors reduce the depth of insertion, but remember, the silicon sheet is 10 millimeters, and you can see that even for the highest scaling factor, the participants did overshoot, so they went into the hard sheet. And finally, for user satisfaction, there's no effect in needle insertion. However, for block transfer, participants seem to prefer the intermediate scaling factors, in particular scaling factor 1.0. So in conclusion, increasing scaling factor reduces the forces in both tasks, perhaps more so in needle insertion, as it is a more sensitive task. Operating time in block transfer is reduced. Again, this is very controversial. We did not consider the docking. It's a sore task, so fatigue is not involved either. The depth of needle insertion is reduced. However, as we saw, it was not enough, so perhaps we should have gone up the scale. And user satisfaction is significantly different for intermediate scaling factors in block transfer. This might be because we trained the participants in block transfer beforehand, unlike needle insertion. However, as others have noted previously, the effect of force feedback is apparent, even though it may not be apparent to the operator. So what is the ideal scaling factor? Well, we argue that instead of having a fixed value, we need to adapt the scaling factor to the task and, of course, to the operator, as different operators have different sensitivities. So finally, for the future, we aim to increase our sample size, use more scaling factors, and perhaps live tissue, compare different masters. So remember I showed you the Fandom Desktop master. We're currently developing a fully pneumatic master with a smaller workspace but able to convey larger forces. And then the next step ahead would be to track the operator in real time. For example, his fatigue through electromyography, or as we heard before about prefrontal cortex activation and the concentration in an attempt to measure immersion. The final step, I suppose, would be taking a bit further and incorporating active constraints for a more safe system. So, to finish off, going back to the first three principles: standardization of training, health inequalities, and portability. These are three things our pneumatic surgical robot covers. So I would like to thank the Kawashima Laboratory. Thank you very much for your attention. I welcome any questions.
Thank you very much indeed for your talk. Any questions from the floor? Yes, Alex.
Lovely and clear presentation, thank you. I noticed your sample size is quite small, just 2. Is there a particular reason for that other than this being very novel work?
Yes, so the main reason is that it is very novel work and that it's still a prototype. The other reason is that I did this work as part of my BSc project, and the time frame was quite small, and we are in a lab of engineers. So the way we did that is that we asked 2 surgeons to partake, and we also then compared it with 2 students, myself and someone else, and we realized that the surgeons did not have enough time, so we lost them in follow-through. So initially we were planning to have 4, so we ended up having 2. And then I know 4 is still a small sample size, but similar experiments have been published with 7 and 4 as a sample size. So we thought we'd start from there, see how these tasks go, and then decide if we need to change the task if it's not optimal, or increase the sample size?
You have a room full of surgeons. I'm sure they'll all be keen to help. So my question is in laparoscopy, obviously we don't have force feedback, so we develop visual cues to adjust for that, so it's specifically guided. Did you look at confounders on your data set? Did you think about what might be influencing that perhaps something you haven't measured?
What might be influencing?
So confounders on the technical performance that might be confounding your data set.
Oh, I see. Yes. So indeed, I suppose in laparoscopy, as studies have shown that the surgeons actually compensate even with the lack of feedback with their experience. So because these data were from 2 students, we thought that the best way to minimize confounding was, of course, randomize it and select 2 completely non-experienced students with laparoscopy, so novices. So I suppose this would be fair in comparing someone to a trained surgeon. However, we did not do anything else to speak to other confounding patients.
Okay, one very quick question.
Yes, quick question on the technical aspect of it. How was the haptic feedback delivered? How was it delivered to the operator?
Yes, so it's fine. So if you remember that slide with the piston and how the robot works, so because the pneumatic, the robot's pneumatic and the cylinder has compressed air in it, when the air goes from the air tank to the cylinder, it pushes the piston towards one way, and if you can imagine the piston moving, so that allows our system to be back drivable, and as it pushes the air towards one side, this difference in pressure between the cylinder, obviously this side will have more pressure, this side will have less pressure. We multiply this difference in pressure with the area of the cylinder, which is constant, which we know it, and then this essentially is conveyed. The arm is connected to cables in a control box where our servo valve actually is, and this is connected to the master device, and then the direct feedback goes from the master device to the operator. So if you can imagine the operator holding the master device, he will feel that through the cables of the servo valve, through the arm. Does that make sense?
Certainly does. Okay, so on that note, we'll finish secondary. Next up, we have Mr. Castro introducing. Again, I think that's correctly introduced. You should talk to us from microscale to the macroscale, really. Translocation of minimal access surgery from randomized controlled trial setting to national practice.
Good afternoon, everyone. My name is Astrid Losing, and today I'll be presenting on the translocation of minimal access surgery from randomized controlled trial setting to national practice. Meta-analyses of randomized controlled trials have demonstrated the short-term benefits and long-term safety of minimal access surgery for major gastrointestinal cancer within a trial setting. However, a clear balance needs to be struck in assigning the patient inclusion and exclusion criteria so as to reduce the effect of confounding factors, but also to ensure that the inclusion criteria are not too strict so that the trial population is no longer representative of real-life clinical practice. When comparing the patient selection between randomized controlled trials and national database studies, we can see that in the randomized controlled trials, we generally have fewer patients with stricter inclusion criteria, and the national studies tend to be larger with a more heterogeneous population group with a significant degree of variation within the patient demographics. When looking at the surgeon and centre selection, these have to undergo quite rigorous credentialing prior to enrolment within a trial, whereas, of course, national series are more reflective of real practice and clinical outcomes relating to the minimal access surgery. So the objective of our study is to compare the clinical outcomes from multi-center randomized controlled trials and national database studies looking at minimal access surgery in both major upper and lower gastrointestinal cancer surgery, and also to establish the external validity and translocation of results from multi-center randomized controlled trials in minimal access surgery to clinical practice outside of the tightly controlled trial environment. In terms of our methods, we performed a systematic literature search from papers from 2000 to 2018, Publications we included in the review were multi-center randomized control trials or national database studies comparing minimal access surgery versus open gastrointestinal cancer resection. And the outcomes we studied included post-op mortality and other post-op complications. The outcomes from the minimal access surgery group in both the randomized control trials and national database studies were then compared, and a meta-analysis was performed on the results. This is just a PRISMA flowchart describing our literature search strategy, and as you can see at the bottom, ultimately the total number of studies we included in our systematic review were 49. In terms of results, so as you can see, on the under colorectal cancer surgery, on the minimal access surgery arm, basically we showed no statistically significant difference in post-op outcomes between the two groups compared with randomized control trials and national series, with a mortality of 1.22% in the randomized control trial group versus national series of 1.31%, and morbidity 31.92% versus 22.86%. However, in the esophagogastric cancer group, comparing randomized trials and national series, 5 out of the 6 total outcomes evaluated showed increase in adverse outcomes within the national series. Further down on the table, looking at the meta-analysis of outcomes, comparing the randomized control trials and national series, we can see that overall 4 out of 5 outcomes had reduced odds ratios of adverse outcomes in the national series group, particularly the mortality and pulmonary morbidity, and the general post-operative morbidity in the colorectal cancer group showed that the odds ratio in the national series was statistically significantly different to the trial group, with a odds ratio of 0.4 versus 0.97. Within the esophagogastric cancer group, overall, the randomized control trial meta-analyses showed improved mortality and overall post-op morbidity. Here are two bar charts just showing exactly what I just described. So on the left, you have the colorectal cancer minimal access surgery comparing the randomized control trials versus the national database study. And on the right, we've got the esophagogastric cancer group, again comparing the two. So randomized control trials of minimal access surgery aim to evaluate the true effect upon the clinical outcome. The design in itself attempts to control the confounding factors. In esophagogastric cancer studies, we showed that the adverse outcomes associated with minimal access surgery was non-significantly increased in the national study group versus the randomized control trial group in 5 out of 6 outcomes. In the colorectal cancer group, however, the point estimates for the odds ratio from the meta-analysis of the adverse outcomes were reduced even more within the national series compared to the randomized trials for 4 out of the 5 outcomes. And this suggests that the benefits of minimal access surgery in colorectal cancer are even greater than those compared in the national study group. And this could be because of the very nature of a randomized control trial in which you are tightly controlling patient selection, and this may prevent the true effect of minimal access surgery being demonstrated. Because as we know, the maximal benefit of laparoscopic colorectal cancer surgery is seen in the elderly and obese, patients which by the very nature of a randomized control trial are excluded. And this is reflected in the comparison of the meta-analysis, showing reduction in adverse outcomes for minimal access surgery in the national study versus randomized control trials. So as I mentioned, randomized control trials undertake a rigorous credentialing process prior to enrolling surgeons and centers in the trial. This is to ensure that surgeons are beyond a certain point in the learning curve, so as to influence operative results and ensure consistent performance. Whereas national studies tend to include surgeons of all stages of the learning curve and centers with variable levels of perioperative care. And this could in fact be partly responsible for the increase in adverse outcomes in the minimal access surgery group for the national study in seen in esophagogastric cancer compared to randomized control trials. So what does the study highlight? It highlights the need to introduce new surgical techniques at a national level, and this can be achieved through structured training programs with competency-based curriculums and measures for assessing competency before embarking on independent clinical practice. A prime example of this would be the National Training Program for Laparoscopic Colorectal Surgery in England. This showed that clinical outcomes are not compromised while trainees gain competency, and that the mortality and complication rates in the trainee cases were equivalent to those performed by experts during their training and subsequent independent practice. So in conclusion, our study highlights the discrepancy in clinical outcomes and treatment effect sizes of for minimal access surgery in gastrointestinal cancer between randomized control trials and national database studies. The randomized control trials tight control of the confounding factors such as patient comorbidities and surgeon-centered performance aim to create a true experimental design to evaluate the impact of minimal access surgery. But as I said, patient demographics cannot be controlled at a national level, and thus the onus in translocating these outcomes from the randomized control trials remains in optimizing surgical technical performance. And as I said, this can be achieved through appropriate validated training programs and similar surgeon credentialing prior to independent practice.
Thank you very much. Any questions from the audience before we move on? So, sorry, yes, question at the back. We might have a microphone for you. Thank you.
Thanks for that great talk. I was just thinking, could part of the effect you're seeing there be due to the increased centralization in UPI relative to colorectal?
Yeah.
And so is it perhaps more of an argument to further that centralization?
Yeah, definitely. I think that's a very good point. I think that could in fact be a factor in there. Yeah.
Okay, but so how do you adjust that then in the analysis of national data?
Okay. It's difficult, yeah, because by the very nature of the national studies that include all sectors.
Yeah. So that means some subgroups.
Yeah.
Also, of course, you had, as you mentioned, the national training program for laparoscopic surgery came halfway through your study period. And now, of course, that's been stopped. It's not been funded. So what does that mean for esophageal gastric surgery? Should we read on to that?
Yeah, so I think the study shows that, if we're to colorectal cancer, potentially something that can be adopted for secondary gastric cancer. And it's definitely something worth considering reinitiating.
Okay, Astrid, we will move on. Thank you very much indeed. Thank you very much indeed. Mr Marsden has the dubious honour of speaking just before lunch. Hold on, everybody. He will speak to us about enhancing decisions for major hemorrhage protocol activation using the Bayesian Network. Thank you.
Great. Well, thanks very much for the opportunity to present our work with you today. Our research looks at a machine learning technique or an artificial intelligence technique called Bayesian networks, and we're particularly interested in trying to support decisions around transfusion. I should say that I work for the military and this work has been funded by the military. I thought I had 9 minutes, I've got 8, so there's going to be a bit of a canter through some of the technical stuff, which you'll be delighted to hear, and then get you through to your lunch. But I just want to really focus on the studies, the clinical studies, which I think are interesting. I'll take you back 8 years. This is 2011, and we're in Helmand province in Afghanistan. That's Private Stephen Bainbridge. And moments before this photograph was taken, he stepped on and detonated an improvised explosive device. There was a 20-year-old medic that was suddenly dealing with a very complicated, polytraumatized patient that would stretch any of the major trauma centers in the country. The medic had seen 1 or 2 of these patients before with similar injury patterns and followed the standard operating procedures he'd been taught. He applied bilateral tourniquets to the patient's near amputations, a sling to the pelvic fracture, and then had some very difficult decisions about what to do next. Did he give the patient the fluid that he'd been holding in his bag? And these decisions are complicated because this medic did not have enough experience to understand how the potential options relate to each other, i.e. giving the fluid or not giving the fluid. And the 2 key interrelated themes are a patient that will develop trauma-induced coagulopathy, and they are very difficult to identify, and who is going to require a lot of blood. Again, very difficult to identify in a pre-hospital space. Trauma-induced coagulopathy is vital to patient survival. The ability of a patient to form a stable clot impacts directly to mortality, morbidity, and resource use. This was shown about 15 years ago. we think that identifying these patients, which, as I said, you cannot do with diagnostics in the pre-hospital space at the moment, is fundamental to deciding on high-risk treatment strategies for these patients. The other side of this coin is who requires a lot of blood. And again, the studies suggest that clinical gestalt, i.e. clinical decision-making, when you see a patient for the first 10 minutes, is only sensitive about 65% of the time. So we, trauma experts, are getting it wrong a lot. So that's where we've turned our decision-making solution, these algorithms, to those two problems. Machine learning, as you've heard today, is a very broad church. The Bayesian Network sort of sits somewhere up here on the family tree. I'm going to skip through this, but essentially Bayesian networks allow us to update a prior held belief given new evidence. And a Bayesian network allows us to put in lots of new evidence to come up with a probability of an outcome of interest. In our case, traumatic coagulopathy. Very briefly, the Bayesian networks have a knowledge structure that we define. And so in the case of traumatic coagulopathy, we put in the key drivers for coagulopathy and then the evidence we want to show the model. And that evidence is taken from clinically obtainable inputs within the first 10 minutes of an HLS primary survey. And we then learn the model using data, and that's where we are able to combine the data with the previous knowledge. And in this example, for our model, we used 600 patients from a prospectively collected sample of trauma patients at the Royal London. So our model looks like that, and it's accurate and specific at identifying patients who have traumatic coagulopathy. And one of the nice features of Bayesian networks is because they're based on knowledge fundamentally, when you show a different population to the model, they generalize very well. And that's what we were showing here with our areas under the curve. So what's that got to do with predicting patients that need blood transfusions? Well, we noticed that for patients that had a higher predicted risk of coagulopathy, that's demonstrated along the y-axis there, the amount of blood that they required up on the y-axis increased. So the study I wanted to tell you about aimed to identify which patients would require lots of blood, a massive transfusion, based on their prediction of coagulopathy. And we did that using a retrospective study design, and we defined lots of blood or a massive transfusion as 10 units of blood in the first 12 hours. And we combined trauma experts at the Royal London and London's Air Ambulance, and we compared the decisions they made. So did they activate the major hemorrhage protocol, which is called a code red in sort of London trauma parlance, with the same information that the models were given at the same time. It's a pretty standard data set of London trauma patients. They're young men who predominantly be injured by blunt mechanisms. And what we found, slightly surprisingly, but good news if you get hit by a bus in London, is that our clinicians are pretty good. They're pretty sensitive. So what I've called clinician gestalt, the ability of a clinician to look at a patient on the roadside and say, or in the emergency department and say, this patient needs a massive transfusion. They were right 86% of the time. Comes with a slight over-triage rate, as you'd expect. One of the properties of this model, which gives you an output from 0 to 100, is you can define where you operate that model. Okay, so you can say, I want a 90% sensitivity, an 80% sensitivity, or a 70% sensitivity. And those different operating points are shown here in this graph. There is a point, the second operating threshold of the model, in which the model performs slightly better than clinicians with a slightly lower over-triage rate. But that is nice. That's good. We're happy with that. But that's really not what this study is about, or our decision support is about. We would like to see how the models and humans work in combination. So what about these patients, the false negatives, the ones that the clinicians missed, that did go on to receive massive transfusions? Well, we were very excited to see that the model identified every single one of the patients that the clinicians missed. The flip side of that is, what about where the model missed the patients? Well, the vast majority of those patients were identified by clinicians. And these are the same patients, but just divided up into those two different model and clinician. So that's very nice. Lots and lots and lots and lots and lots of people have published about this. There's 36 models in the literature that define similar retrospective studies and say, look how good we are. And the NICE guidelines for major trauma say don't use any of them. So why are we better, or why could this be better? Well, we're hoping that by doing some prospective implementation studies, that we'll be able to show that our model not only can affect decision making, and this is a study of 50 patients, clinicians, prospectively, given the model result and asked to make their predictions on blood transfusion and coagulopathy with and without the model, we can see that the model is effectively tuning the decision-making process of our clinicians. And as you've heard previously, it does look like who the decision maker is important. And so for the last year of my PhD, I've had the opportunity to perform my data collection in a jumpsuit, which for a surgeon is awesome, and I'm collecting data with London's Air Ambulance and trying to understand prospectively whether these decision support tools will be able to help patients like Private Bainbridge and junior decision makers in the real world. In conclusion, I think Bayesian networks would be able to demonstrate, can identify who needs massive transfusion, can help us to help support junior and senior decision makers, and hopefully, if I'm invited back, I should be able to tell you some stats in the future about how to get on. Thank you very much.
Thank you very much, Matt. Any questions? So yeah, we have one at the back. Yeah.
Thanks, Matt, for that great talk. I'm just wondering, the reason for NICE rejecting all previous studies, is it because they were all retrospective? And is that how you plan to overcome that problem?
Yeah, so that's a really important point, thank you. So of all of those models that have been developed previously, none have got these implementation studies to show that actually in the real world they affect clinical decision making. And that's key, because without those, a retrospective study, we just do not know how it's going to perform. So, yes.
And so with your study, it's the first prospective study, is that right?
Yeah, so there are other people with other types of models that are around the world looking at these, and there's different ways to try and predict who's going to get coagulopathy and require transfusion, but none are published yet. So,
are you randomized?
Yeah, thank you for that. So a year of my PhD work was trying to get MRHA approval, because these devices are now regulated, like a new drug. And at the moment, it's blinded. The clinicians are blinded to the model outcome because we haven't demonstrated its accuracy prospectively. And we hope in the future that it will be a large multi-centered trial where we randomise or perform another trial design. But at the moment, we can't give the model outcome.
Does it work with different mechanisms of injury? So you've got a blast injury in Afghanistan, and then you've got a stabbing in East London.
Yeah.
Does the model work depending on what?
Yeah, so it's a really good point, and thanks. I'm sorry I didn't really have much time to go into how that model was structured. But one of the input variables is mechanisms of injury, and one is the kind of injury and the energy associated with that injury. If you're shot with a handgun or shot with a high-speed rifle, they're different if you fall from 2 foot or 20 foot. There's different mechanisms. But yes, as long as there are enough patients in the training data set that the model understands the relationship.
You trained it on 600 London patients, and then you want to apply it to 200 Scottish and Afghans.
Yeah. So sitting in with a foot in both camps, we're also training with what's called the Joint Trauma